And the world of medical research, um, it is incredibly rare to find what you'd call a true smoking gun.
Oh, absolutely. It almost never happens like that.
Right. But imagine this. If you take a person who is prone to migraines and you give them an intravenous infusion of a specific tiny protein, it will reliably trigger a massive delayed migraine attack almost every single time.
Yeah, it's not just, present at the scene of the crime. It is actively causing the crime.
Exactly. And today, we are hunting down that protein. We're doing a deep dive into a really comprehensive clinical document from the Migraine Surgery Specialty Center. You can actually review all their work at headachesurgery.com.
Mm-hmm.
But our mission today is to demystify one of the biggest buzzwords in modern headache medicine right now, which is CGRP inhibitors.
And it's a massive topic. I mean, it carries incredibly high stakes for you listening because we aren't just talking about, a standard tension headache that you can just sleep off with a nap.
Yeah, not at all.
Chronic migraine affects roughly 3 to 4 million Americans. These are individuals who are fundamentally losing days of their lives. They're missing work, retreating into dark rooms, totally unable to participate in their own families.
That's exactly why this deep dive feels so critical. We are going to explore the biology, the history, the real-world results, and crucially, the hidden limitations of these cutting-edge drugs.
Right, because there are limitations.
Big ones. And if you stick around, we're going to look at a fundamentally different mechanical alternative for the people who fall through the cracks of medical therapy.
Which is a surprisingly large group of people.
It really is. But to understand how these new drugs work, we really have to look at the villain they're targeting first. So what is this protein we're infusing into people in these clinical studies?
Well, that villain is calcitonin gene-related peptide. CGRP for short.
CGRP.
Okay,
Yeah.
it's this 37 amino acid neuropeptide that was actually first isolated back in 1982 by researchers at the Salk Institute.
Wow, 1982.
Yeah, it's been around a while, and at its core, CGRP is one of the most potent vasodilators known in human biology.
Vasodilator meaning it opens up blood vessels.
Exactly. Its primary job, when released, is to drastically widen your blood vessels.
So scientists find this incredibly powerful vasodilator in 1982. How long did it actually take them to figure out it was the driver behind migraines? Because, for a long time, the public narrative was just that migraines were some kind of, random weather event in the brain.
Right, like a stress thing or just bad luck. What's fascinating here is that the dots weren't fully connected until the 1990s.
Okay.
Pioneering researchers, specifically Lars Edvinsson and Peter Goadsby, they firmly established CGRP as the central mediator of the migraine cascade.
So they finally mapped it out.
They did. They mapped out the anatomy and showed that CGRP is heavily concentrated in sensory neurons, specifically within the trigeminal system.
And the trigeminal system is what exactly?
It's this massive nerve network responsible for almost all the sensory input and the pain signaling in the head and the face.
Okay, so when you say it's a mediator, what is actually happening physically in someone's head during an attack? Because the source document mentions neurogenic inflammation being triggered by this protein. But what does that actually mean for the person experiencing it?
Well, think of it as a localized biological panic response.
A panic response. I like that.
Yeah, so when the trigeminal nerve endings are irritated, they basically dump massive amounts of CGRP into the surrounding tissue, specifically the meninges.
The meninges, right. Those are the protective layers surrounding the brain.
Exactly. And because CGRP is this potent vasodilator, the blood vessels rapidly expand, but it also causes the blood vessels to become leaky.
Leaky. Wait, like fluid is leaking out of the vessels.
Fluid and immune cells just rush into the surrounding tissue. So that swelling, that fluid leakage, and that intense sensitization of the nerves so that they literally throb with every single heartbeat, that is neurogenic inflammation.
Okay, let's unpack this. So is CGRP basically like an overly sensitive biological fire alarm? And when it gets pulled, it triggers a massive flood, this vasodilation and neurogenic swelling right there in the brain's trigeminal system.
Building on that analogy, it's not just a single alarm, though. It's a networked security system.
Oh, interesting.
Because the CGRP receptor itself is a complex molecular structure distributed all throughout the trigeminal ganglion, the dura mater, the brainstem nuclei. It's everywhere.
So it's totally systemic within that pain pathway.
Right. And because it's so widely distributed, if you can block that receptor, if you can jam the signal so the alarm can't communicate with the sprinkler system, you have the potential to interrupt the entire migraine cascade at a molecular level.
Which sounds like an absolute silver bullet.
Yeah.
But look, if they figured this out in the 1990s, why did it take nearly 30 years for these drugs to become the standard of care?
It's a great question.
I mean, once you know the fire alarm is the problem, don't you just build a chemical to shut it off?
You'd think so, but early development hit a major wall regarding how the body processes medications. The first attempts to target this therapeutically happened in the early 2000s. Scientists developed small molecule receptor antagonists, which they became known as gepants.
Gepants, right.
Yeah, the mechanism was perfectly sound. They blocked the CGRP receptor directly, but the early oral versions, like one called telpegepant, they failed dramatically around 2011.
Failed how? Like,
Right.
did they just not stop the migraines?
Oh, no, they stopped migraines.
Oh.
Yeah, they worked. But they caused elevated liver enzymes when dosed frequently.
Ah, liver toxicity.
Exactly. Because these were small molecules, they had to be metabolized hepatically, meaning the liver had to filter and process them.
Right, like most pools you swallow.
Yeah, and taking them daily as a preventative measure simply overwhelmed the liver's enzymes, leading to unacceptable toxicity. That essentially just shut down their use as a daily preventative drug.
Wow. It's incredible how often in medicine a drug does exactly what you want it to do in the brain, but your liver just says absolutely not.
Right. The liver is the ultimate gatekeeper.
So how did the scientific community pivot from that failure?
Well, the real breakthrough era arrived between 2018 and 2020 with a completely different vehicle for delivery: monoclonal antibodies, or MABs.
Okay, MABs.
This fundamentally changed the landscape of headache medicine. You've likely seen these names in medical literature or even television commercials: erenumab, fremanezumab, galcanezumab.
And there's an IV version too, right?
Yep, eptinezumab.
So why did these monoclonal antibodies bypass the liver issue? Like, what makes them so different from those early Gepants?
It basically comes down to molecular size and design. Monoclonal antibodies are massive proteins compared to the tiny molecules of the early Gepants.
Oh,
Because they are so large, they don't cross the blood-brain barrier. They remain in the peripheral circulation. And more importantly, they aren't broken down by the liver's enzyme pathways.
so the liver just ignores them.
Basically, they're degraded into amino acids by the body's reticuloendothelial system over a much, much longer period.
Which means no liver toxicity.
Correct. And because they have incredibly long half-lives, meaning they stay active in the bloodstream for weeks, they only need to be dosed via a subcutaneous injection once a month.
Oh, that's so much easier.
Or sometimes via infusion once a quarter. And around the same time, I should note, researchers also figured out how to refine the gepants.
Wait, they brought the Gepants back?
They did. The second-generation gepants, like ubrogepant and rimegepant, were formulated with excellent liver safety profiles.
Okay, so the liver can handle these new ones.
Exactly, making them viable for both acute rescue, taking a pill right when you feel a migraine starting, and for prevention.
I want to clarify who exactly is a candidate for this level of intervention, because you don't just prescribe a monthly injectable monoclonal antibody for someone who gets, like, a stress headache once a year. Who are the clinical targets here?
Oh, the indications are highly specific. It's based on the concept of a disabling threshold. The preventive monoclonal antibodies are designed for episodic migraine prevention, meaning patients having up to 14 headache days a month, but severe enough to cause impairment.
Up to 14 days is already half the month.
It's terrible. And they're also indicated for chronic migraine prevention, which is defined as 15 or more headache days a month. There's also an indication for episodic cluster headaches.
And what about the refined Gepants? If you already have these monthly injections, where do the acute rescue pills fit into the picture?
The acute gepants offer a mechanism-specific option that is incredibly valuable for patients who cannot tolerate older rescue medications.
Like the triptans.
Exactly. For a long time, the standard rescue drugs were triptans. But triptans work by constricting blood vessels.
Right.
Which means they carry cardiovascular risks.
Yep.
If a patient has a history of heart issues, triptans are totally contraindicated.
That makes sense. You don't want to squeeze the blood vessels of someone with heart disease.
Right. Or, frankly, many patients simply stop responding to triptans over time anyway. Gepants give those patients a rescue option that blocks CGRP without causing that systemic blood vessel constriction.
Okay, so we have the arsenal. We know what these drugs target, and we know who they are designed to help. But I want to look at the real-world application here.
Okay, let's do it.
Because in reading through the Migraine Surgery Specialty Center document, there seems to be a significant gap between the excitement of the initial clinical trials and the actual patient experience. How well do these drugs actually work?
This is where we have to view efficacy in terms of probabilities rather than guarantees.
Right.
When you look at the primary endpoints for these CGRP inhibitor trials, the gold standard metric is the 50% responder rate,
Meaning the drug cuts their migraines in half.
meaning the proportion of patients who achieve at least a 50% reduction in their total monthly migraine days.
Okay.
Across all the approved monoclonal antibodies, the data consistently shows that about 40 to 60% of patients hit that mark.
And what about the people not on the drug?
The placebo response in these trials is usually around 20 to 75%. So the true drug effect provides a meaningful, distinct benefit, but it is far from universal.
I'm going to push back on that metric heavily, though.
Go ahead.
Why is a 50% reduction considered a resounding success? I mean, if you're listening to this and you suffer from 20 severe migraine days a month, dropping to 10 still means you are spending a third of your life non-functional in a dark room.
It does sound bleak when you frame it that way.
10 days of debilitating pain still sounds like a highly disabling condition.
That is a very valid perspective, but it requires looking at what happens to the nervous system during chronic migraine.
Okay, explain that.
When someone is experiencing 20 migraine days a month, their nervous system is in a state of constant systemic windup. We call this central sensitization.
Central sensitization.
Yeah, the nerves become so hyperreactive that even light touch can feel painful.
So they are essentially living in a constant state of biological inflammation, even on the days the pain isn't at a peak.
Exactly. So dialing that down by 50% doesn't just mean erasing 10 calendar days of pain. It means reducing the baseline sensitization. Oh, I see. Often the 10 migraines the patient does still experience become far less severe. They respond much faster to rescue medications, and the postdrome, that intense hangover-like fatigue following an attack, is shortened.
That's a huge difference.
It is. A 50% reduction can fundamentally alter their disability status, changing the reality from being entirely unable to hold a job to being able to manage a relatively functional life.
Okay, that makes a lot of sense when you reframe it as turning down the volume of the entire system. And the resource does point out a smaller group of patients who experience an absolute miracle.
The super responders?
Yeah. It mentions that 5 to 15% of patients in individual trials are categorized as 100% responders.
Complete elimination of their migraines. Going to 0 days of pain for a condition that was previously considered refractory is an incredible outcome for that specific 5 to 15% subset.
But blocking one of the body's most potent natural vasodilators continuously for months on end, it isn't without consequences. Let's talk about the catch.
There's always a catch.
If I'm taking these medications, what am I sacrificing elsewhere in my biology?
Well, while CGRP inhibitors are generally well tolerated compared to older daily preventatives, they certainly have a side effect profile. You see common issues like injection site reactions, redness, swelling, that sort of thing.
Sure.
But the systemic side effect that has garnered the most attention is severe constipation.
Really?
Yes, which is particularly notable with the drug aranumab.
Why that drug specifically? And honestly, what does a brain peptide have to do with your gut?
It goes back to the mechanism. Aranumab specifically targets and blocks the CGRP receptor itself, whereas the other antibodies bind to the circulating peptide.
Ah, okay.
And it turns out those CGRP receptors are densely populated throughout the human gastrointestinal tract.
Oh, wow.
Yeah. CGRP naturally plays a vital role in regulating gut motility, the muscle contractions that keep digestion moving along.
Okay, so when you block those receptors systematically, you effectively slow down the gut's transit time.
Exactly.
So you're turning off the fire alarm in the brain, but you're also paralyzing the conveyor belt in the stomach.
That's a strong way to put it, but mechanically, yes. The rates of clinically meaningful constipation are 3 to 4 times higher than with a placebo. Post-marketing surveillance has even reported severe cases leading to bowel obstruction requiring hospitalization.
Wow. So anyone utilizing these therapies has to aggressively monitor their GI health.
Absolutely.
But there's another major system that relies heavily on blood vessels. You mentioned earlier that CGRP is a vasodilator. What happens to the heart when you remove its ability to widen blood vessels?
This is the cardiovascular paradox of CGRP inhibitors. In a healthy resting state, blocking CGRP doesn't seem to drastically alter blood pressure.
Okay, so resting is fine.
But during an ischemic event, meaning a moment when blood flow to the heart or brain is restricted, like a heart attack or a mini-stroke, the body naturally upregulates CGRP.
So it floods the system with this vasodilator.
Yes, to forcefully open the coronary arteries and protect the tissue from dying.
So it's literally a built-in biological safety net for the heart.
Yes. And the theoretical concern is, if you have blocked CGRP long-term with a monoclonal antibody, you have removed that protective mechanism right when the heart needs it most.
That sounds incredibly risky for anyone with a history of cardiovascular disease.
It is. It's why patients with known coronary artery disease, uncontrolled hypertension, or a history of stroke were largely excluded from the pivotal clinical trials.
They weren't even tested.
No. We also see that these drugs can exacerbate conditions like Raynaud's phenomenon.
What's that?
That's where the tiny blood vessels in the fingers and toes spasm in response to cold, restricting blood flow. If your body already struggles to keep those peripheral vessels open, blocking a natural vasodilator is clearly counterproductive.
Right. And the fact that certain people were excluded from the trials leads us directly into a massive blind spot, highlighted by the Migraine Surgery Specialty Center document. We're talking about patients with unremitting, constant daily headaches.
Right.
People who literally do not have a single pain-free minute in a month.
The most severely affected end of the spectrum.
Right. If you have 15 distinct migraines a month, a clinical trial can easily measure if you drop to 7. You hit the 50% responder rate. But if a patient is drowning in a continuous, never-ending flood of pain, how do they measure a 50% reduction? Do the trials just leave them out entirely?
Unfortunately, yes, they do. The standard endpoints of episode frequency simply do not apply if the episode never ends. Most trial protocols for these CGRP inhibitors explicitly excluded patients who presented with a headache on every single day of the month.
Which means the patients suffering the absolute most have the least amount of clinical evidence supporting the very drugs they are desperately being prescribed.
It's a huge gap in the data.
And to compound that, these drugs are incredibly expensive. The resource notes they cost anywhere from $600 to $900 a month out of pocket.
Yeah, the financial burden is real.
And, as we established earlier, 40 to 60% of people simply do not respond to them anyway.
It is a really sobering reality. For all the brilliance of the neurochemical approach, it leaves a highly disabled population behind. Whether due to cost, severe GI side effects, cardiovascular risks, or simply falling into the non-responder category, thousands of patients find themselves back at square one.
Which brings us to the fundamental question. When the chemistry fails, what is left?
Exactly.
I'm stuck here. If we just spent the last 20 minutes proving that migraines are a chemical cascade driven by CGRP, how do we treat someone who doesn't respond to chemical blockers?
We move from chemistry to anatomy.
Anatomy. Okay, this is where the document really takes a turn. Instead of trying to alter the molecular signaling of the brain with massive proteins, this surgery looks for physical anatomical compression.
It operates on a completely different paradigm. The concept is that the peripheral sensory nerves, specifically the trigeminal and cervical nerve branches running through the face, the scalp, and the neck, can become physically compressed or trapped by the surrounding anatomical structures.
We're talking about bones, muscles.
Yeah.
What is actually trapping the nerve?
It can be tight fascial bands, enlarged muscles, bony foramina, which are the small holes in the skull that nerves pass through, or even crossing blood vessels that just pulsate against the nerve.
That sounds agonizing.
It is. This chronic physical irritation generates a persistent pain signal. That signal travels back into the brain, constantly triggering the release of CGRP, perpetuating that central sensitization we discussed earlier.
Wait, so the physical entrapment is actually causing the chemical release?
Yes.
It's like untying a physical knot or removing a clamp from a wire. It sounds almost exactly like fixing a pinched nerve or a herniated disc in your lower back, but for a migraine.
That is a highly accurate comparison. Just as a herniated disc mechanically compresses a spinal nerve and causes radiating leg pain, a tight muscle in the forehead or neck can compress a cranial nerve and trigger a radiating migraine cascade.
Makes total sense.
Releasing that compression surgically eliminates the peripheral mechanical driver of the pain.
But how can a doctor possibly know if a patient's migraine is caused by a pinched nerve versus just an overly active brain chemistry? I mean, you can't just operate on everyone and hope you find a tight muscle.
You absolutely don't, and that is where the diagnostic bridge comes in. Targeted peripheral nerve blocks.
Okay, nerve blocks.
This is the critical screening tool. If a patient has failed CGRP inhibitors and other medications, a surgeon can inject a small amount of local anesthetic to temporarily numb specific trigger sites in the head and neck.
So they essentially turn off the switch locally in the tissue to see if the alarm light goes out in the brain.
Exactly that. If the nerve block temporarily completely stops or significantly reduces the pain, it proves the pain cascade is being generated at that specific anatomical site.
Wow.
A robust, reproducible response to a nerve block is a strong clinical predictor that releasing that specific nerve surgically will be effective.
And the efficacy data for this approach is staggering. The document states that for carefully selected patients who have failed medical therapies like triptans and CGRP inhibitors, the published evidence shows an up to 93% success rate.
Up to 93%.
Up to 93%. And they define success as at least a 50% reduction in migraine frequency, duration, or intensity, with many of those patients achieving complete elimination of their pain.
It is a profound outcome. It is vital to remember we are talking about a patient population that has already failed the most advanced pharmacological options science has to offer.
And this ties back perfectly to the blind spot we talked about earlier, the constant, unremitting daily headache patients, the individuals totally excluded from the drug trials.
Yes. For patients with unremitting, constant pain, the root cause may very well not be episodic chemical release, but rather sustained mechanical compression.
Because a physical entrapment doesn't ebb and flow like a chemical cycle.
Yeah. Exactly. It constantly, relentlessly grinds on the nerve. For this specific population, peripheral nerve decompression surgery represents what may be the only evidence-based treatment option available that addresses the root cause rather than trying to mask the chemical symptom.
It is an incredible journey when you step back and look at the whole picture. I mean, we started with the isolation of the CGRP fire alarm peptide all the way back in 1982.
Yeah.
We saw the scientific community struggle for decades through the early liver-toxic gepants,
Right.
eventually finding massive success with large protein monoclonal antibodies and safer next-gen gepants. We look at the reality of those drugs, the life-changing relief they provide for about half of patients, which is obviously offset by the $600 to $900 monthly costs, the severe GI side effects, and the cardiovascular risks.
Mm-hmm.
And finally, we explored the vital anatomical alternative, peripheral nerve decompression surgery for the people who fall through the cracks of medical therapy.
It really highlights how highly individualized and multifaceted migraine treatment must be. But, if we connect this to the bigger picture, there's a lingering unknown with the chemical approach that we haven't fully resolved.
Oh, what are we missing?
Well, we know CGRP is intricately involved in pain signaling, but we also know it plays a crucial physiological role in bone metabolism, in wound healing, and in modulating our immune system's responses.
Okay.
As millions of people begin blocking this peptide continuously every single month for decades, what unknown long-term effects might we see?
Oh, wow.
How will our bones heal after a fracture? How will our immune systems function 10, 20, or 30 years from now? The oldest of these monoclonal antibody drugs was only approved in 2018. We simply do not have the long-term, multi-decade safety data yet.
That is a massive question mark hanging over the biological chain reaction. We know how to turn off the fire alarm now, but we don't truly know what else that alarm was quietly regulating in the background. It is definitely something for you to mull over as you digest all of this information. We do need to leave you with one final, very important note. This deep dive is intended solely as an educational resource to help you understand the complex landscape of migraine science. It is not medical advice. All medical decisions, whether about starting medications or exploring surgical options, should be individualized and directed by a physician.
Very true.
Thanks for joining us as we explore the storm, the flood, and the science of getting your life back. We'll catch you next time.